I really appreciate the opportunity to be here, even if I didn't really expect to say anything, because I've been talking kind of about what CDC has been doing, give regular reports at the CFSAC meeting, but I was very pleased to be invited to be part of this conversation, because I feel that what this community needs is everybody working together. And we are a willing partner, and I think that I'm pleased to have the opportunity to make that more and more connections. And so what I'm going to do is just kind of give you mostly a review or an update of what CDC's been doing for you lately. We have been working on our web pages. And we published a summary of our roundtable meeting. And you can find it under the sections of meeting and workshops. And the roundtable meeting itself was one of our most important initiatives last fiscal year, where we brought stakeholders together and gave them an opportunity to really talk to each other about how to best get the information about the IOM report out on our web pages. And we had the ability to explain what our web pages were, what we can and what we can't do. We have since that time updated the section for the general public to reflect the IOM recommendations. And we did this based on the input that we got from the roundtable meeting, as well as, of course, the IOM report. And our pages for healthcare providers are currently under construction. We hold regular meetings, which we call our stakeholder engagement and communication calls. They used to be called PCOCA calls, and the name got changed because there was another entity at CDC that thought they would get confused with that. The most recent call that we had was with Dr. Navio, who talked about metabolomics, which you can hear here is an area of great interest. And we have our next call scheduled tentatively for November 2nd. And some of you here have graciously agreed to participate, and it's going to be a discussion of the IOM report. And Dr. Peter Rao and Lucinda Bateman will be participating along with Ellen Clayton. And this actually was a recommendation of the IOM report that CDC should use one of these conference calls to increase awareness in the community about what is in the IOM report. Now, we did have an observance of ME/CFS Awareness Day, and this year we did it in collaboration with NIH. And I think that's, again, one of the good signs of progress in the field, that the government agencies are really able to communicate better and build on each other's strengths. And we did collaborate on this. And in the corner is the group at CDC. We have a blue wall, so it worked out really well for our blue day. That looks like a huge group, but it was everybody in my branch, even if they weren't working on ME/CFS, wore blue. And in the corner is our Deputy Division Director, Jenny McQuiston. And so the division is really behind us on this initiative too, which is really very good. A lot of young people, which is really good. And this field needs more young people. We've started publishing on our MCAM study, which is the multi-site clinical assessment of ME/CFS. And this was the first paper to come out, and we were really pleased that it got picked as an editor's choice in the American Journal of Epidemiology, which is a really good journal. Now, we've had presentations at various meetings, and one of them is the ME ME colloquium that was in London. There again, we presented the work that we're doing with the multi-site study and the information that we plan to get from that study. We presented at the focus meeting, which Vicki told you about, that was an NIAID organized meeting. And so I presented a little bit on the public health problem of ME/CFS. Again, it was to help set the stage for the rest of the immunology presentations. And then just, I think it was last week or the week before, anyway, early in October, I attended the immunogenomics meeting, which is held in Huntsville, Alabama, and had a pilot project that we did on our ME/CFS patients, looking at the T-cell receptor immuno profile, very small study. We had some hints that there were some differences, and I really was not comfortable presenting it because everybody had amazing data. But the organizer said, who was my collaborator, really wanted me to talk about it. And so I did. And it was amazing how much interest there was. And it was an audience of about 50 to 100 people. I don't have an exact count, but they're really smart, high-tech group. And there was so much interest in this illness and why it's still a mystery. And that's the kind of, so that was a great, to me, a victory. Wasn't so much what we did, but explaining the illness and getting their interests. So we also have other activities that are ongoing. We are continuing our multi-site clinical assessment of ME/CFS. We are in a, what do you call it, no-cost extension phase, where we want to really finish up the last bit of work that we're doing, and that it will include the NK cell function testing that we're doing on these patients. And we are also supplementing MCAM. Now, with the 7 clinicians and clinics that we're collaborating with, have done a really great job, but they focus on adult patients. And it's been really hard to enroll pediatric patients. So in our supplemental contract, we're actually going to really go to clinics that specialize in pediatric patients. And we're also trying to enroll clinics that see patients other than ME/CFS. And I'll come to that a little bit later, why we think that's an important part to supplement. One of the other important things that we're doing is increasing our collaboration or continuing our collaboration. We work very closely with CFSAC and through CFSAC in the work groups, both the pediatric and the medical education work groups. And we're collaborating with NIH on the common data elements. And there again, I think, I sort of pick what I think is the most important initiative of the year. This common data elements really will form a base for, I believe, moving the field forward, and is really, really important. And so we're glad to collaborate with NIH, and NINDS has the infrastructure in place to house those common data elements, and CDC did not have that. So this is really a natural partnership. And as Vicki indicated, it is a work of the whole community together, and that's been another strong benefit of the field, of the project. We're also collaborating with a group to help advance some of the questionnaires and markers for clinical outcomes assessments, and that's a project that FDA is very, very interested in. And so some of the data from MCAM can be used to evaluate the effectiveness of patient-reported outcome measures. So we have plans for more continuing education events. One of the most critical needs is doctors that understand this illness. And those of you that are clinicians are aware of how long your waiting lists are. I have learned as I went around to visit how hard it is to get new clinicians interested in this field. And we really need to do a better job of education. So we have continued our our continuing education initiatives. And we have something unique that's coming up, and that is kind of a partnership to show an edited version of the Unrest film in a continuing education approved format. We're just this close to getting it approved so we can get it out. It'll be held the end of November. Dr. Klimas is going to be part of the panel. And so the idea is that we'll show the film, so the healthcare providers will get an idea really of what the illness is like, and then have a panel discussion. We have a contract that we have awarded to Medscape to do a continuing education activity through them. And as part of this contract, there'll be a component to evaluate the effectiveness of the learning and try to have better metrics on who's taking it and how to reach that audience. But the focus, again, is going to be on primary healthcare providers, because we feel that what we've been told is that's where the patient's entry into the healthcare environment is, through primary care, and there's just still a lack of understanding. And then this last one is just one little phrase here, but is probably one of the most important things that we're doing, and that is we are starting the process of developing a plan to describe how we can get to formal treatment guidelines. And we agreed to do this. You'll see CDC's response to a CFSAC recommendation. So CDC does not envision that we'll do this alone, but what we're doing is we're gathering information and going to come up with a plan that will be brought back to the community, describing what are the steps that we'll take and will lead the field towards formal treatment guidelines that can be then established and then renewed every 5 years, which treatment guidelines have to be. And I think that will solve, one of the questions was, should we redo an IOM report? But something like this, in order to have treatment guidelines, the literature has to be reviewed as part of that and summarized. So that will be, could be incorporated all into that work product. And so I work at CDC and try to view everything through a public health lens. And there are many important public health questions that we feel need to be addressed. And these include, this is just a partial list of what are the best instruments, tests, and physical examination methods for diagnosis and treatment impact. And in particular, we're always looking for very practical tools for the clinicians that they can use in their office. How can risk factors for ME/CFS be identified, and so that we can identify approaches to both prevention and intervention? What is the relationship of ME/CFS to post-infectious fatigue? This is a natural for CDC, looking at infectious disease outbreaks. And is there going to be an impact of all these emerging infections on the incidence and prevalence of ME/CFS? Related to that, how can we come up with more simplified methods for surveillance so that we can identify trends? Current surveillance methods are very cumbersome and or imprecise, and so we constantly have that in mind. I don't have the answers, mind you, I just have questions. And finally, just a little comment based on CDC's experience. Dr. Limpkin mentioned CDC being involved in providing samples to look at born disease virus, and so CDC has been active in this field for many, many years, has done studies, and we've learned some things. And one of those that I see being taken up in the field is that stress of some kind can accentuate the differences between ME/CFS and a comparison group. This can be something like a Trier social stress test, it can be an exercise challenge, but it's sort of the body at work where you sort of emphasize the differences. And then this one, the heterogeneity of ME/CFS, I believe, is really what is limiting this field. It is very frustrating for everybody to have ideas that are not replicated in the next study. And one of our hypotheses for having our 7 clinics together was to ask whether is it the fact that the patients are different between the clinics. And we think the answer is no, it's not that the patients are different between the clinics, the patients themselves at each clinic are very heterogeneous. So we have to have better ways to account for that and not just do simple case versus control. That's just not going to be feasible anymore. And these are just some of the factors that you're all aware of that contribute to that heterogeneity. And one of the ones that is, I think, hardest to deal with is the medications that these patients take, huge numbers of medications in some cases, that most of the study methods we have cannot really take those into control. And finally, I want to just comment on the importance of the comparison group. This is important because pretty much any doctor can tell this is a healthy person versus a not healthy person. And so many of our case and control study, you know, the controls are all healthy patients. If we want to really get to diagnostic markers that's really going to help the clinician, we need to be able to distinguish ME/CFS patients from patients that have other illnesses that present with fatigue and some of the other symptoms that are present. And so that's why we have emphasized trying to include an ill comparison group in our studies. This can be, will help us look at which questionnaires and which symptoms and which methods will help doctors really be able to focus in and ask the right questions so they can improve the diagnosis. And then finally, synergy and collaboration. CDC has things that can help researchers. We have some experience with study design and instruments that's being fed into the common data elements. We have some independent cohorts that have been collected materials. We are constructing our biorepository from the multi-site study that will be available for hypothesis-driven research. And we have some varying experience with data analysis and methods. So with that, I'd like to thank you again.